All right, so what we're going to start with this evening is I want to walk you through the process of how to think about things and to ask yourself certain questions about how to name things and how to prepare and how to study things and how to figure out actions and things of that nature. So, just to throw out some key words here that you should be reviewing. So, based on this, this is a muscle of the cranium. You can see it's near the temporal bone. So, this region here is the temporal bone, right? Remember, this is the angle of the mandible or the ramus. This is the mandible down here. This is your frontal bone. Here's your occipital bone. Up here is your parietal bone. So right here is your temporal bone. Now, some muscles are named by a variety of ways. And I have a little silly mnemonic. I call it SOS land. SOS land. So S could be for muscles could be named by their shape, like deltoid muscle, trapezius muscle, rhomboid muscle. Those are muscles named by their shape. O, SOS. So O for origin. Muscles can be named by their origins and insertions. A muscle like the SCM muscle, which is the sternocleidomastoid. When you look at that name, sternocleidomastoid, it is given its name by its origin and insertion. So sternocleido, sterno for sternum, cleido for clavicle, sternocleido, and mastoid for the mastoid process, which is behind the ear here. This muscle right here happens to be the sternocleidomastoid. So this muscle is named by its origin and insertion. I'll give you another example of an origin insertion muscle. One of the forearm and the arm called the brachioradialis. So brachio for brachium, like arm, and radialis for the radial bone. So brachioradialis tells you it has to be somewhere associated with the arm and the forearm. Okay, SOS. So the next S is going to be size. Muscles could be named by their size. Gluteus maximus, large. Gluteus minimus, small. Rhomboid minor, small. Rhomboid major, large. Um, let's see. Flexor carpi radialis longus, long muscle. Flexor carpi radialis brevis, brief, short tendon, short muscle. So you look for these keys in the words SOS, land, LAND. L for location, muscles are named by their location. How about a muscle like tibialis anterior, tibialis posterior, right? Both of those tell you a lot about their location. Tibialis anterior, it's got to be in front of the tibial bone. Tibialis posterior, behind the tibial bone. How about location? How about this? This one here on the screen, temporalis. It's near the temporal bone. Frontalis, near the frontal bone. Occipitalis, near the occipital bone. Mentalis, near the mental, near the mandible. All right, so that's L for location. A and D, land. A, action. Action, how about opponens pollicis, flexor pollicis, adductor pollicis, extensor pollicis? Pollicis we know is thumb, and the action words is the first one. Maybe it's a flexor pollicis if it flexes the thumb. Maybe it's an adductor pollicis if it adducts the thumb. Okay, how about N for number? Biceps, triceps, quadriceps. It tells you the number of tendons. Biceps, 2 tendons. Triceps, 3 tendons. Quadriceps, 4 tendons. What do we mean by tendons? These are the parts of the muscles that attach to bone. and bones can move, right? When muscles contract, they transfer that contractile tension or that force to the bone by way of that inelastic soft tissue called a tendon. And then the tendon attaches to the periosteum bone and it makes it contract. Okay, and some tendons are referred to as origins and some tendons are referred to as insertions. The origins are usually the more proximal attachment, whereas the insertion tends to be more of the distal attachment. The origin is the part of the bone that typically stays still, and the insertion is the part of the bone that moves. So most muscles have an origin and an insertion. The origin stays still, and the insertion is the more movable part. Okay. And then we have direction. Muscles can be named by the direction of the fibers, like, let's see, the middle fibers of the traps, upper fibers of the traps, lower fibers of the traps, abdominal oblique, transverse abdominis. It tells you the direction that the fibers tend to run in. All right, so that's a little background to how muscles could be named, SOS land. Muscles contract. This is skeletal muscles, of course. Skeletal muscles contract. And the types of contraction can be concentric, eccentric, or isometric. Typically, when we talk about concentric, we are saying that the origin of the muscle and the insertion of the muscle are moving closer together. They're approximating. And eccentric would be when the origin and insertion are moving further away from one another, whereas the muscle or the tendons are elongating. Now they're elongating back to their resting state. They're not elongating past their anatomical position. That would be silly, right? Because if you stretch a muscle or tendon past their anatomical position, then you'll be damaging the muscle and tendon. You can strain it, it can tear. Isometric is when there's tension that's generated in the muscle and tendon, but there's no change in the joint angle. Think of a person like a bodybuilder that's holding a pose. When they hold a pose, the muscles are contracting, but there's no change in the joint angle when they're in tension holding the position. If you're pushing against a wall and the wall's not moving, you can feel muscle tension generating through your body. Okay, that would be isometric. Okay, so we talked about the different types of contraction. The thing that you'll have to review a little bit, and I do have some videos on this. Hopefully you subscribe to Nutrition Chirodoc. I do have some videos there on the sarcomere, which is the structural and the functional unit of muscle. And that's where all of the magic that takes place in terms of muscle contraction, how does the muscle actually contract, is at this neuromuscular junction, the NMJ, the neuromuscular junction. So I do have a video on muscle contraction and muscles, and I walk you through the relationship between actin and myosin. Those are your structural proteins. And then we talk about those proteins are also the contractile. When I said structural proteins, they're the contractile proteins, actin and myosin. Actin is more of the thinner filaments, and myosin are the thicker of the two filaments. And then we have regulatory proteins, which is like the on and off switch that regulate muscle contraction, and that would be troponin and tropomyosin. So it's this really unique relationship between troponin, tropomyosin, the regulatory proteins, and how those regulate the contractile proteins, actin and myosin. And the other buzzwords that you should also review is calcium's relationship to muscle contraction and the neurotransmitter ACH, which is acetylcholine. ACH is acetylcholine. That is always an excitatory neurotransmitter at the neuromuscular junction. What is the neuromuscular junction? It is the junction or the union between the nerve and the muscle. Okay, and there's a lot of neat things that happen there. But calcium is important, acetylcholine is important, the sarcomere is important, the sarcoplasmic reticulum is very important. That actually stores calcium. And then you'll be learning about depolarization, which is where sodium rushes into that cell and creates an action potential or a nerve impulse. So depolarization, sodium rushing in, action potential, they're all kind of revolving around each other. Okay, they all have something very much in common. All right, so here we have what structure is highlighted. So you have to go, all right, well, this is the mandible. This looks like it's the coronoid process of the mandible. This is the mandibular condyle. So this is the temporalis. This happens to be one of your muscles of mastication. There are 4 muscles of mastication. I refer to them as the T.I.M.E muscles. And here they are, T.I.M.E. See what I wrote here, T.I.M.E.? Just think of it as it's time to eat. These are your chewing muscles. Mastication means chewing. The T is for temporalis. The M is for masseter, which is here. So then what is the I and the E? The I and the E are the lateral pterygoids and medial pterygoids. Well, you're going to say, well, where the heck is the I and where the heck is the E? At this point, with reference terminology, you need to know that lateral is external and medial is internal. So there's a lateral pterygoid up here, and then there's a medial pterygoid here. So T.I.M.E, temporalis, internal pterygoid, masseter, and external pterygoid. So the masseter and the temporalis, these are like chewing up and down, right? That allows your jaw to go up and down, but you don't just chew up and down. If you think about chewing a piece of gum, your jaw does deviate side to side, and that is the function of the lateral and medial pterygoids. They kind of grind and move the jaw left to right, okay? So up high in alignment with the maxilla, that's the lateral pterygoid. I work on these frequently with patients that have TMJ dysfunction. You'll hear people say, oh, I have TMJ. Everyone has TMJ. TMJ just stands for temporal mandibular joint, TMJ. But temporal mandibular joint dysfunction, now that's something else, okay? So usually what happens is if someone gets clobbered in the mouth, they get punched, they get elbowed, they fall on their face as a kid, they're not paying attention, they turn their head and they bump into a bar or something, like anything, it can deviate the jaw. And when the jaw deviates side to side, you get muscle trauma. And the trauma reflex kicks in. And when the trauma reflex kicks in, muscles become tight. Just think about if someone's going to punch you in the stomach, how your abdominal muscles tighten up as a reflex. So the trauma reflex, now you have muscles on one side of the jaw that could be tightening, and whenever muscles are tight, it pulls the bone to the tight side. Now you have dysfunction where you don't have a lot of movement on one side, but lots on the other. And then the articulation starts to change in their shape. So many times I have to put a glove on my finger, slide my finger, follow the inside of the maxilla, inside the oral cavity, go all the way back to this point here and work on myofascial release of these tendons here. It works wonderfully. I get so many referrals from orthodontists and from local dentists because there's very few doctors that know how to treat this. Okay, and it works very, very effectively. All right, so these are the 4 muscles of mastication. Now, here's a muscle that's called, if you think back to week 1, when we learned anatomical position, there was the buccal area, which was the cheek. And this is a muscle called the buccinator. The buccinator, this is like the trumpet muscle. When you blow into a trumpet or blow into a balloon and your cheeks puff out a lot, that is the buccinator. Well, let's look here. We have to really look at what's happening. So here we see the jaw. Look like the bone is cut. The bone is cut here and here. Up high, this was the one I was telling you I treat with some of my patients. It's one of the T.I.M.E muscles. Well, it's not the temporalis, and it's not the masseter. It's not the buccinator. It's not the medial pterygoid. This one is the lateral pterygoid up here. Okay. Now this one's the medial pterygoid, right? Lateral pterygoid is up here. Here's the medial pterygoid. Here's the buccinator. Here's the orbicularis oris. And we'll talk about these eye muscles in a little bit. There are some 6 major eye muscles, which we'll get into. Let's look at some of these neck muscles. I put this picture up here because it shows a few things. Number one, right in the center, we're looking at the person from the posterior, from the back. We could see the spine. We see the scapula here on the left. We could see the trapezius with the upper fibers of the traps, the middle fibers, and the lower fibers. When we dissect the trapezius away and we peel this back, we will see what we see on this side. We could see the rhomboids. So we have rhomboid minor up here and rhomboid major. But with the traps superficial to that, you can't see them. So you have to peel these away. You have to dissect it to see what's deep to it. You also have to dissect the trapezius away in order to see the muscles that are on the scapula, which we'll talk about shortly. These are some of the rotator cuff muscles. Here's a muscle called the levator scapula. And the levator scapula has its origin way up here at C1 to C4. It originates on the top 4 cervical vertebrae and inserts right there on the superior angle of the scapula. And by its name, levator scapula, it sounds like elevator scapula. It elevates the scapula, like shrugging your shoulders up. Like when you say, I don't know, it's your scapula that elevates, and then your humerus just comes along for the ride. But it's the scapula that's actually elevating, levator scapula. Origin is the top 4 cervical vertebrae, C1 to C4, transverse processes, and then it inserts on the superior angle of the scapula. Okay, what do we have here on the side of the neck? There's your sternocleidomastoid. That's your SCM. Sternum, clavicle, that's your origin. And then the insertion is right there next to the ear on the mastoid process. Here's your trapezius. And just next to the trapezius, like if you peel the trapezius away here in the middle and you deflect this back, what's deep to it, we can see on the right-hand side, there's the splenius capitis, right? It goes right to the capitis, which is the skull on the back, splenius capitis. If we dissect the splenius capitis away and then we dissect the levator scapula, now we're looking off to the right. What's deep to those are these suboccipital. That means under the occiput. These suboccipital, these are very, very short, powerful muscles that go from the base of the occiput to C1, right? Some of these go from the occiput to the C1 vertebrae. And then some of them go from the C1 vertebrae to the C2 vertebrae. It kind of makes this triangle. Can you see this triangle? They call it the suboccipital triangle right here. What's really unique about this is that what these anatomists found not long ago, maybe 20 to 25 years ago, right? Anatomy doesn't change. They just do different dissections from different angles. They found that one of these suboccipital muscles, I'm going to see if I can remember, it's been a while since I mentioned it. It is called the rectus capitis posterior minor. Rectus capitis posterior minor actually has an attachment to the meninges. Well, what's the meninges? We haven't done neurology yet, but the meninges is the soft tissue layer that protects the spinal cord and the brain. So they found a bridge or an attachment, which is probably why people get these suboccipital headaches, because when there's muscle tension to these suboccipitals, especially the rectus capitis posterior minor, there is this bridge of attachment to the dura mater, which is a meningeal layer around the spinal cord and the brain. So very, very powerful. And when these muscles are tight, they can subluxate a vertebrae, especially the atlas, and creates a lot of complications. When we get into neurology, when we get into neuro, we'll talk about the medulla and the atlas vertebrae and the vagal nerve and all of the implications that can arise from that. Okay, so just wanted you to get a little bit oriented here. So you have the trapezius that's superficial. If we cut that away, you could see splenius capitis. And again, you'd have them on both sides, of course, of the vertebrae. And then if we cut these away, what's deeper to that are these suboccipital muscles. Okay? So now if we look here, well, what structure is highlighted here? If we were to take a look, well, we see the sternum, we see the clavicle, and we can assume that this is going behind the ear. So the only muscle that we've covered up until this point that this could possibly be is the SCM, or the sternocleidomastoid. When this muscle contracts bilaterally, it can flex the head. But when it contracts unilaterally, here's what it does. When your right SCM contracts on the right side, it brings your right ear to your right shoulder, kind of like being on the telephone. It tilts your head. That's called right lateral flexion. But it rotates your head to the left. Okay? When your left SCM contracts, it does left lateral flexion, bringing your left ear to your left shoulder, but it rotates your head to the right. Okay? All right, what is this asking? What is the origin of the highlighted muscle? So here we're not even asking what the muscle is, but now it's asking for the origin. So now you have to go back and go, oh my God, you know, what bone is here? So if it gives you choices and it says, is it the mastoid? No, it doesn't look like mastoid. Is it the mental foramen? Well, no, mental is chin. That doesn't look right. Is it the supraorbital foramen? Well, no, that's up here. Is it the frontal bone? No, that's up here. Occipital bone? Well, that's in the back. Zygomatic arch? Ah, zygomatic. Yeah, that could possibly be. Okay, so that's how you have to kind of think about things. Also, process of elimination. Let's look back here. This looks like it's the splenius capitis muscle here. But what's this one, the purple? Well, the only thing that we've covered before is, can't really see the scapula, but it is going up to the cervical vertebrae on both sides. That would be your levator scapula, to elevate the scapula. Well, what's the insertion of that? Well, what's the origin is up here. That's the C1 to C4 transverse processes. That's the origin. The insertion is that superior angle of the scapula. It's that superior angle, a little bit of that medial border, but mostly superior angle of the scapula. Let's look at the eye muscles for a second. So here's the nose, here's the orbit. There are 6 eye muscles, and we are going to look medial, right? The nose would be here. If we look at this picture, the nose would be here. This is the person's right eye looking at us. We don't see the left eye, we don't see the nose, but this is their right eye. We're looking at them. So 4 of the muscles, 4 of the 6 have the word rectus in it. The one on top, superior rectus. Well, the one on the bottom, inferior rectus. Well, that's cool. Okay. The one on the inside, medially, is the medial rectus. And the one on the outside, externally or laterally, that's the lateral rectus. So no big deal, right? Superior rectus, inferior rectus, medial rectus, lateral rectus. That's 4 of the 6. There's two others. They're called obliques. There's one on top called a superior oblique, and there's one on the bottom called the inferior oblique. Okay. All right, so those are the 6 eye muscles. So if we go back here, right up on top, that's the superior rectus. There's your inferior rectus. Here's your lateral rectus, and there's your medial rectus. What are the 2 left? Those are the obliques. The one on top, right there, that's your superior oblique, and the one on the bottom wrapping around this way is the inferior oblique. These obliques kind of create torsion of the eye. They kind of rotate it around. So here, this is the nose. We're looking at them from the lateral side. This one looks like it's on top, but it's wrapping around. So what do you think that would be? Right up here, this is the lateral rectus. That's the superior rectus. That's the inferior rectus. You can't see the medial because we're looking at it from the lateral view. This is the inferior oblique. So on top, you got the superior oblique. What structure is highlighted here? Well, again, superior oblique is on top, superior rectus, lateral rectus, inferior rectus. That has to be inferior oblique. Okay, let's look at the muscles of the anterior shoulder. These are muscles that are going to move the arm. When we talk about arm, we're talking about this, the humerus. The humerus is the arm, same thing as the shoulder. When we talk about forearm, the forearm is the radius and ulnar, which is down lower. Arm is shoulder. So what are the superficial muscles? Well, you got the pectoralis major here. You got the deltoid. You have the biceps. These are all shoulder muscles. They're all muscles that move the humerus. If we peel back the pectoralis major and the deltoid, then we're looking at this person's, our reading right, but this would be the person's left shoulder. Here's the biceps. Biceps brachii. There's bi means 2. So you got 1, 2 heads. One is the short head, the other is the long head. The long head goes through that bicipital groove. The short head originates right there on that coracoid process. Remember the coracoid process of the scapula? The shoulder summit up here is the acromion process. So the acromion process articulates with the clavicle, and this joint right there is the AC joint, the acromioclavicular joint, the AC joint. Sometimes when people have a bad shoulder injury and they land, sometimes the clavicle goes down and the acromion process sticks up and you get this little step off deformity up on the top. And when you palpate or feel someone's shoulder, they have this significant high spot there. That's usually a dislocation between the acromion and the lateral part of the clavicle. So this is the AC joint, the acromioclavicular joint. Here is the sternoclavicular joint, because that's the manubrium of the sternum, and that's the medial clavicle. That's the manubrium, this is the body of the sternum, and this is the xiphoid process at the very tip. All right, what else do we see here? This is the ribs cut away so we can see the anterior scapula. The subscapularis is one of the rotator cuff muscles. And it's the only one really that you can see from the anterior view, but it originates on the anterior scapula. And this is called the subscapular fossa. The subscapular fossa is the origin of the subscapularis. Here's teres major. It's not a rotator cuff muscle. Teres minor is, but not teres major. So here we can see a few of the rotator cuff muscles. Here's the trapezius on the left. Here's your deltoid. Here's your large lats, or the latissimus dorsi. And believe it or not, the lats is a shoulder muscle. It does originate on the lower 6 thoracics, all of the 5 lumbars, the sacrum, the ilium. This large origin right here, they call it the thoracolumbar aponeurosis. And an aponeurosis is just a broad, flat tendon. is what it is. When it's a broad, flat tendon, it's an aponeurosis. So the latissimus dorsi originates on the thoracolumbar aponeurosis. And look at these fibers. It's large. They kind of wrap around. They go under the inferior angle of the scapula, but it inserts on the bicipital groove of the humerus. And the bicipital groove of the humerus is on the anterior shoulder between the greater and lesser tubercle of the humerus. The bicipital groove is also known as the intertubercular groove. And the lats are a major adductor of the shoulder, right? It adducts the shoulder, brings it towards midline, and it's a pretty powerful shoulder extensor. Think of it as in the Northeast here, right? You can start a snowblower, right? You have to pull that cord, pulling the cord back, that shoulder extension and adduction. If you're starting a lawnmower, same thing. It's the lats, latissimus dorsi, because it adducts the shoulder and it extends the shoulder. If we peel back the trapezius here, we can see rhomboid minor and rhomboid major. These go from the spine to the vertebral border of the scapula, or the medial border of the scapula. And rhomboid minor originates here between C7 and T1, and it goes to the vertebral border or medial border of the scapula. The rhomboid major goes between T2 to T5, and it too goes to the vertebral border or medial border of the scapula. Minors are always above majors. When I say above, I mean superior or higher up. So here's rhomboid minor, rhomboid major. And what do these do? Well, when origin and insertion move closer together, the scapula moves closer to the spine. We call that scapula adduction or scapular retraction. Okay, and it also can downward rotate the scapula, because if you look at the fibers, the direction of these fibers, the scapula will adduct, but it will downward rotate, or the glenoid cavity will point downward as the inferior angle moves upward. So it kind of like, it rotates it like a steering wheel. The left side goes up, but the right side goes down of the steering wheel. So this side rotates up, but the glenoid cavity is the reference point, points inferior or downward. So they can call that downward rotation or inferior rotation. Here's the spine of the scapula. So you have your supraspinatus, below the spine of the scapula. You have the infraspinatus. Then you have your teres minor and your teres major. These three are rotator cuff muscles. SIT, S-I-T. Supraspinatus, infraspinatus, right there, and teres minor. Supraspinatus, infraspinatus, and teres minor. Those are the rotator cuff muscles, or at least three of the four. Fourth is on the anterior side. That's the subscapularis. The other thing I wanted to point out was, look at the triceps back here. This is the lateral head, and right here is the long head. Notice the long head pierces right between teres minor and teres major. It kind of gets sandwiched. And just like you had rhomboid minor, rhomboid major, here you got teres minor, teres major. Minors are always above majors. And then looky here, there's your levator scapula again, going from C1, C2, C3, C4, that's the origin, to the superior angle, and a little bit of that vertebral or medial border, and it elevates the scapula. So on the right-hand side, you can see three of the four rotator cuff muscles. Here's the spine of the scapula. So above it is the supraspinatus, below it, infraspinatus, and there's teres minor. These three, 1, 2, 3, they insert right there on the greater tubercle. These three rotator cuff muscles insert on the greater tubercle. On the anterior part of the scapula, there's your subscapularis. So this one originates on the subscapular fossa. This one originates on the supraspinous fossa. This one originates on the infraspinous fossa. Now, what are their actions? The supraspinatus abducts the shoulder. The infraspinatus and teres minor externally rotate the shoulder. So supraspinatus abducts the shoulder. The infraspinatus and teres minor, these two externally rotate the shoulder. And then the subscapularis internally rotates the shoulder. So I just remember it this way. I go AB, EX, EX, IN. AB, EX, EX, IN. AB, EX for external rotation, EX for external rotation, and IN for internal rotation. Abduction, external rotation, and then internal rotation. Those are the rotator cuff muscles, the sits muscles. And they all rotate except for that one, the supraspinatus. It doesn't rotate, but the others do. The supraspinatus really initiates shoulder abduction. It does probably the first 15, 20 degrees of abduction of the shoulder is initiated by the supraspinatus, and then the middle deltoids really kick in. They're pretty powerful. So what are we looking at here? What is the action of the pectoralis major muscle? So pec major, if the origin is here on the sternum and the clavicle, and the insertion is here on the bicipital groove of the humerus, since the muscle is medial and the insertion is lateral, it's got to pull that arm in. So that is shoulder or arm adduction. Okay? And it also internally rotates the shoulder. Just think of bodybuilders, right? Think of real powerful, strong bodybuilders. Their pecs are very, very strong. And then what happens is that their arms internally rotate and they end up walking looking like a gorilla, right? When their pecs are really strong, the arms rotate internally. So when they walk, you see the back of the hand. When you see the back of the hand, that's called internal shoulder rotation. That creates a lot of shoulder damage later on in their life because of all that chronic torsion of the head of the humerus in the glenohumeral joint. All right, what's the action of this muscle? So you have to know, okay, that looks like a back muscle, but it's going up. This is the widest muscle of the back. That's the latissimus dorsi. This here is that thoracolumbar aponeurosis, and it goes up and attaches to the humerus. So what is the action of the lats? It can extend the shoulder, but it also adducts the shoulder. Because look at these fibers. They run in this direction, on this diagonal. So if the arm is up here, it can certainly adduct to bring the arm back to midline. All right, what muscle is this? We have to look at our anatomy here. We have to go, okay, this looks like the triceps. This is teres minor, teres major. Here's the scapula. This is the vertebral border. This is rhomboid minor, rhomboid major. This is the lats, the latissimus dorsi. This is your levator scapula up here. So this is that rotator cuff muscle that's below the spine of the scapula. That would be the infraspinatus, which is an external rotator. Now here's the abdominal muscles. There's your rectus abdominis. Here's your obliques. Here's the bicep muscles. Here's the clavicle. So what's this? Well, we're looking at the anterior clavicle. So the anterior scapula. So what muscle is on the anterior scapula? Well, the fossa is the subscapular fossa. There's one major rotator cuff muscle that's there, and that is the subscapularis, and that's your internal rotator. Now we're looking at the back muscles. Here's the scapula. What were diagonal muscles that go from the spine to the vertebral border? One was up here between C7 and T1 to the vertebral border, and the other one below it was T2 to T5 to the vertebral border. Well, that is your rhomboid minor. So rhomboid minor is that C7 T1 spinous process. and it goes to that medial border of the scapula, rhomboid minor. Rhomboid major is T2 to T5 to the vertebral border of the scapula. Okay, now this one is an interesting muscle. This is one that will come up in the discussion board. I'll go through that too. This one here is the serratus anterior muscle. And the serratus anterior originates on these upper ribs, and then it wraps around the thoracic rib cage and tucks underneath the scapula. And it attaches on the anterior scapula, but along the vertebral border or the medial border. And its job is to kind of keep both of the scapulars flush against the rib cage. Where if it's weak, you get the scapulas that wing away. They wing away from the thoracic ribs. Common with young kids. Young kids between the ages of 3, 4, 5, 6. If you ever look at these kids at the beach or at the pool, you can see that the vertebral borders or the medial borders of their scapulas wing away from their ribs because they're weak. So that's the serratus anterior. Make sure you take some time to look at the origin and insertion of that muscle. Okay, moving along, on the top left here, looking at the biceps, which we did before, and there was a short head and a long head. Make sure you know the difference. On the posterior view, there was the triceps. And again, there's a lateral head, and then there is a long head. And the long head pierces between teres minor and teres major. Now, the biceps crosses two joints, right? It crosses the shoulder and it crosses the elbow. And because it crosses it on the anterior part of the arm, it can flex the shoulder and flex the elbow. The triceps is on the posterior side. It crosses the shoulder and the elbow, so it can extend the shoulder and it can extend the elbow. This little muscle right here, many have never heard of it. It's a very, very short muscle called a supinator muscle. It's called a supinator muscle back here. We'll show it to you in a little bit. Oh, I'm sorry, my bad. Supinator I'm going to get to. This muscle back here is called the anconeus. Anconeus, not the supinator, my bad. Anconeus muscle. It is a very short, powerful elbow extensor. Okay, lower left and lower right. So the lower left is the anterior forearm, and the lower right is the posterior forearm. On the anterior forearm, they all tend to be flexors of the wrist. Anything that's on the anterior forearm that crosses the wrist, they're all going to flex the wrist. And what's true on the posterior side, anything on the posterior forearm, posterior radius and ulnar, that crosses the wrist, they're going to be extensors. They're going to extend the wrist. So flexors of the wrist are on the anterior forearm, extensors of the wrist are on the posterior forearm. So this is a biggie here, the brachioradialis. You heard me mention this muscle earlier on today. Brachio, because it originates on the brachium, the shaft of the humerus, and radialis, because it inserts on the styloid process of the radius, brachioradialis. Pronator teres, it's going to pronate the forearm, right? Its action is to pronate. Then look at these. If you look at their names, like flexor carpi ulnaris, flexor carpi radialis, well, flexor carpi, it's going to come down and the tendons are going to cross the carpals, but more on the radial side. This one is flexor carpi ulnaris. It's a flexor, it crosses the carpals, but on the ulnar side. Not too bad, right? If you look at their positioning and these basic concepts, if it's on the anterior forearm, flexes the wrist. Posterior forearm extends the wrist. So when we look back here, well, here's the biceps brachii. What do we have? Well, there's a short head and a long head. Here's the coracoid process. So this is the short head which makes this one the long head of the biceps brachii. What is the action of the triceps? Well, this was nice. Here we're telling you this is the triceps. All you got to do is come up with the action. So you have to look for either elbow extension, forearm extension, or shoulder extension, depending, because it does cross two joints. What structure is highlighted? Well, this here is the long head. The long head of the triceps pierces between teres minor and teres major. And this is the lateral head of the triceps, because it's lateral. What is the insertion of the highlighted muscle? Well, you got to go, well, what is this? Let me look at what's here. So this is elbow flexor. This is the brachialis, right? So there's the biceps brachii, the brachioradialis, and then there's this one, that's the brachialis, okay? So the brachialis, this one here is going to originate on the mid-brachium, and now where is it going to insert? This is going to be on the proximal ulna, okay? The proximal ulna. What is the action of the brachioradialis? Well, biceps brachii, brachialis, and brachioradialis, these are all elbow flexors. They're all elbow flexors. What is the origin of the brachioradialis? Well, you have to first know it's the brachioradialis, so brachio is the brachium. So this one's going to originate on the shaft of the humerus, okay? And the insertion is down here on the radial styloid. Okay, now this, we're looking at anatomical position. This one is the pronator. This is the pronator teres. So if you were holding a screwdriver and you wanted to, with your right hand, and you turned counterclockwise, that's pronation. When you, with your right hand, go clockwise, that's supination. There's a supinator muscle for that, but this is the pronator teres muscle. This is the supinator. This is a silly question, right? Look at that. What is the action of a supinator muscle? Well, the supinator muscle will supinate the forearm or supinate the wrist. What structure is highlighted? Well, that little purple one there, that's the supinator. It's very short. So you want to be able to look at, and I would look at those from an antagonistic perspective. Look at the supinator and look at the pronator. The pronator is called the pronator teres, but the supinator is just referred to as the supinator. So one is going to pronate. It's going to go from the medial epicondyle of the humerus, and it's going to go to the radius. And when you have origin and insertion, the radius rotates over. That's pronation. Okay, these two, a little bit blurry, but all I want to tell you here is just take a look at the abbreviation is ECRL and ECRB. Look at the ECRL and ECRB. It stands for extensor carpi radialis longus and extensor carpi radialis brevis. Look at the extensor carpi radialis longus and extensor carpi radialis brevis, just to be able to look at the difference of those muscles and tendons. This is posterior forearm. This is the back of the hand. So it has to be an extensor. This is the thumb, so this is the radial side. This is the pinky, so it's the ulnar side. So we'd have to give this a name. I would call it the extensor carpi ulnaris. Extensor carpi ulnaris. And of course, when you have choices to select from, it's a little bit easier. Without choices, it's a little bit challenging. Okay, when we look at the thigh, this is the anterior thigh muscles, and this is the posterior thigh muscles. I put these here as reference, so as I move along, you can always come back to look at that. But generally speaking, in the front of the thigh, we have quadricep muscles, and there's 4 of them, the 4 quads. They're called the vastus sisters. So there's the vastus medialis here. There's the vastus lateralis here. There's the vastus intermedius here. That's 3. And then the 4th is this one that's cut. That's called the rectus femoris. So the 4 quadriceps are the 3 vastus sisters, vastus medialis, vastus lateralis, vastus intermedius, and the most superficial rectus femoris. Those are the 4 quads. Those are in front of the thigh. And then on the reading right, these are the posterior superficial thigh muscles. We have the 3 hamstring muscles. And of the hamstrings, 1 of them is lateral and 2 of them are more medial. The one that's more lateral is the bicep femoris, and the 2 that are more medial are the semibrothers. They're called the semimembranosus and the semitendinosus. Semimembranosus and semitendinosus. What's cut here, this is the posterior side, these are the glutes. So you can see the gluteus maximus, that large one is cut, and then there's a gluteus medius, that looks like it's cut. So we can see the gluteus minimus, the piriformis, and some of these other deep muscles. Okay, so that you have to cut the superficial ones in order to see the deep ones. Doesn't that make sense? Okay. So here, it's asking, what is the insertion? Now you're going, what is this? All right, here's the sacrum, here's the femur, here's the ilium. This looks like it could be a glute muscle. It looks pretty large. What's the insertion? Well, I don't know. It's got to be something around the femur, right? The origin's here. The insertion is here. It's more distal. So by process of elimination, could you figure it out? Ischium, ischial tuberosity, well, that's over here. Can't be that. Iliac crest, well, that's up here. Can't be that. Pubic crest, well, that's in the middle. Can't be that. Iliac fossa, that's up in here. Can't be that. So the only possibility is the gluteal tuberosity of the femur, right? So sometimes if you don't know, look at the other choices and you can always eliminate it. What is the origin of the proximal attachment? Okay, so now we're looking at the other, this looks like it's the gluteus medius. And again, let's look at some of these choices. Ischial tube, that's down here. Greater trochanter, well, that's the insertion. They're asking for the origin. Lesser sciatic notch, greater sciatic notch, now those are back here. Can't be those. The ala of the ilium, yeah, that's up here. So that's the origin of the proximal attachment. Now we're looking at the, this is the rump, this is the gluteus, back here are the hamstrings. So by choices, you would have to go, all right, this is the lateral hamstring. Which one is it? Now, the lateral hamstring is called the bicep femoris, and I need you to take a close look in your book and look at the clear delineation of what does the short head look like and what does the long head look like. The long head crosses the hip joint. It's not showing it here. So this would have to be the short head of the bicep femoris, not the long head. Now these are the medial hamstrings, and it's asking what is the insertion. So you have to go, all right, origins up here. I'm looking at the purple down here. So that's the tibia. I got to find something with tibia in it. Well, it can't be the head of the fibula. That's here. Can't be lesser trochanter. That's up here. It can't be the patella. That's down here on the anterior side. The only possibility is the medial condyle of the tibia. Right? So process of elimination. What is the action of the quadricep femoris? Well, the quads are going to extend the leg. These are powerful kicking muscles. So when you kick a football, kick a soccer ball, that strong contraction makes the quadriceps contract. Now, That's three of the, actually all four muscles will extend the knee or extend the leg. One of them can also flex the hip, and it's the only one muscle that crosses the hip. So none of the vastus sisters cross the hip joint. So the vastus lateralis, medialis, and intermedius, they only act on the knee. But the rectus femoris, that one originates off the anterior inferior iliac spine. So that one does cross the hip. So that could do hip flexion and knee extension. Think of a person running and then they want to jump over a hurdle, right? When they jump over the hurdle, the hip has to flex and the leg has to extend. That would be the rectus femoris. That contracts here and here. The other thing I want you to look at, I want you to spend some time looking at the adductor muscles, because this one here is called the pectineus, but then there are three other adductors, and they all have the word adductor in it. So there's the adductor longus, the adductor magnus, and the adductor brevis. So you have three adductor muscles: adductor longus, adductor magnus, and adductor brevis. This one is neither of those three. It's the one that's the most superior, and it's referred to as the pectineus. Pectineus. This one is the adductor longus. So this one here is the pectineus. This one is the adductor longus. Okay. Okay. Then similar concept. Remember what we talked about with the forearm, where anything that was in front of the forearm flexes the wrist and the fingers, and anything on the back of the forearm extends the wrist and can extend the fingers. Similar principle, but now we're talking about the leg, but you can see that the anterior leg muscles cross the ankle. And then the posterior leg muscles cross the ankle. So any of these muscles in the front that cross the ankle, they dorsiflex the foot. And anything on the back side, plantar flex the foot. So dorsiflexion is if you're walking on your heels. Plantar flexion is if you're walking on your tippy toes. So this is a very powerful dorsiflexor, this one here. It's called the tibialis anterior. This is one, if you dorsiflex your foot and invert it at the same time, meaning turning the sole of your foot in and adduct, and you look at your foot, you can actually see this tendon popping up. It's very, very distinct. Tibialis anterior. When this muscle is damaged, or the nerve that goes to it is damaged, the nerve that goes to it is called the deep peroneal nerve. When it's damaged, you get a person that walks around with an altered gait called foot drop. And when they walk with foot drop, these are people that when they walk, they take a very, very high step intentionally so that the toes and the foot do not drag on the floor. They call it a steppage gait because they're taking a very, very high step with their foot. Okay, so that's the tibialis anterior. And just next to it, we have extensor digitorum longus. These, if you look at the belly of this muscle and you follow the tendon down, you see you have 1, 2, 3, 4. These are the extensor tendons. They're going to extend the digits 2, 3, 4, and 5. These are extensor digitorum tendons. They extend the toes up, but they also cross the ankle. So they dorsiflex the ankle. The general rule of thumb that you have to remember is if a muscle or tendon crosses the joint, it has to act on the joint. If it doesn't cross the joint, it can't do anything at that joint. Okay. All right. On the back side, you can sneak a peek at two muscles that we'll cover shortly. These are posterior muscles, the gastrocnemius and the soleus. You can see a little bit from the anterior because they do bulge out laterally, but they are posterior muscles. Okay. So anything on the anterior leg, this anterior compartment will dorsiflex the foot, and if they cross the toes, they'll extend the toes upward. These are the posterior muscles. So here's the gastrocnemius. There's a lateral head and a medial head. The lateral head is lateral because that's where the pinky toe is, and the medial head is medial on the inside. Look at these two muscles. They come down. Here is the tendon, and it attaches to the calcaneus. The tendon is called the Achilles tendon. This is one of the most commonly ruptured tendons in the body. And when this tears, the gastroc balls up. It just shrivels and moves superiorly. And it's very, very painful. There are people that have to use antibiotics, and it's really important to make sure that the antibiotic that you take does not cause tendinopathies. My wife's cousin several years ago used an antibiotic, and he was walking, and the Achilles just snapped. So you have to be real careful with certain antibiotics. They create tendinopathies, mitochondrial dysfunctions, and they tend to weaken the musculotendinous junctions, especially the Achilles tendon. So here's the gastrocs and here's the soleus, both of these attached to the calcaneus by way of the Achilles tendon, and these are plantar flexors. That means stepping on your tippy toes. Just think of a person that wears heels. It gives very, very nice shape to the gastrocnemius because the foot is in a plantar flexed position. The other thing I wanted you to see is these lateral tendons. These are called the fibularis longus and fibularis brevis. Sometimes they're called peroneus longus and peroneus brevis. These are lateral muscles. They go around the lateral malleolus. Okay. So here we're looking at this muscle, and let's take a look. Let's see if we can figure this out. Is it the tibialis anterior? Well, we are looking at it from the anterior, but that's more medial. Okay. Is it the soleus? Well, the soleus is more posterior. So now we're looking at either fibularis longus or fibularis brevis. So what you need to do is you need to go and look and compare, is it the fibularis longus, is it the fibularis brevis? But there is one more that we need to consider. Could it also be the extensor digitorum longus? The extensor digitorum longus also goes to the toes 2, 3, 4, and 5. Okay? So here, now we're looking at the posterior leg muscles. Okay, I know we're getting close to the end. Hang on there. So what we did here is we took off the gastrocnemius, we took off the soleus, and now we look at what's deep to behind the leg. There's a muscle here called the popliteus. We call it the key that unlocks the knee because it immediately rotates the tibia in order to allow the knee to flex. And then we have three muscles that I call Tom, Dick, and Harry. Tom, Dick, and Harry. The Tom, the T, is tibialis posterior. Tom, Dick, the D, flexor digitorum longus. And then Tom, Dick, and Harry, H, flexor hallucis longus. The Tom, Dick, and Harry are these deep posterior muscles. They all go behind the medial malleolus and go underneath the foot. They're posterior leg muscles that move medially behind the medial malleolus and go underneath the foot. So here, this is the posterior, this is the popliteus, this is the knee. This is the tibialis posterior. This one here is got to be, let's go back, it's a medial muscle. Let's look. Here, it's medial flexor digitorum longus, right along the inside. Okay. And then this one is asking, okay, well, what is the insertion of the highlighted area? Well, this is the calcaneus. So whatever that structure is, it is inserting on the calcaneal bone. Okay, what is this? What is the action? Well, we know it's the rectus abdominis, and its primary function is to flex the trunk. You have these oblique muscles. These will rotate the trunk. Okay. So let me stop the recording here.